Everyone should have received an alert that I am now recording officially, and we'll give it about a minute and a half before we begin.
Here she is. Tony, also do a quick check when Laura gets on, please.
Of course. Hi, Laura.
Hi, I apologize for being less than timely.
You're here. That's all that matters. Thanks, Laura.
You bet.
Laura, so your audio sounds great. I'll do a quick rundown with you. So how you see it now with the grid on with everyone here, this is how the attendees will also see everyone. You do have the ability to mute and unmute yourself. You also have the ability to turn your camera off and on. I do recommend keeping the camera portion on for the duration of it, since this is how the attendees will view everything. If you're not speaking, I do recommend muting your audio there, just in case there's any background noise. And then you don't have to worry about the chat or the Q&A feature. That'll be handled by Marie, who will moderate the questions at the end to you all. Do you have any questions before we begin the webinar?
I don't. Thank you.
Great. Okay. So we are recording, and I am hitting start webinar now and handing it over officially.
Good afternoon. I'm Sister Mary Haddad, President and CEO of the Catholic Health Association. The Catholic Health Ministry in the United States has a legacy of compassion that stretches back to 1727, when religious sisters first arrived to care for people who were poor and marginalized. Nearly 300 years later, that mission endures. Today, more than 1 in 7 patients in the U.S. receive care in a Catholic hospital. Each year, Catholic hospitals provide care to approximately 88 million patients, including 4.5 million inpatient visits, 19.5 million emergency room visits, and over 99 million outpatient visits. This ongoing commitment to healing and service reflects the deep roots and enduring promise of Catholic healthcare in communities across this nation. The Catholic Health Association is the largest network of nonprofit healthcare providers in the U.S., representing more than 600 hospitals and 1,600 long-term care and other health facilities. Together, we serve millions of patients and families across the country, in urban, suburban, and rural areas, and in communities both affluent and underserved. I'm pleased to be joined today by Wright Lassiter III, CEO of CommonSpirit Health, Laura Kaiser, President and CEO, SSM, Chantel Krebs, President and CEO, Avera St. Mary's in Pierre, South Dakota, Gabriella Sines, Senior Vice President, CHRISTUS Health, and Brad Coffey, Senior Vice President and President of Covenant Health Foundation. Yesterday, the Senate Finance Committee released the draft text of its legislation, which, based on our preliminary review, would impose even more restrictions on provider taxes, state-directed payments, work requirements, and care for immigrants. As we have stated, these changes to existing law would place additional burdens on many of the Medicaid patients we treat, while also limiting states' ability to finance their Medicaid programs. We hope that as senators review this new language, they listen to the experiences of our members who will be negatively impacted by these new proposals, and instead, together, champion policies rooted in compassion and dignity to ensure that everyone has access to affordable healthcare coverage. In short, the bill unconscionably creates Medicaid cuts even further, which will only result in more people losing coverage, more facilities struggling to stay open, and more people not able to get the life-saving care that they so desperately need. CHA remains opposed to several provisions of H.R. 1 because the bill would harm critical health and social safety net programs that millions of Americans rely on to live with health, dignity, and security. The Catholic Health Association strongly opposes provisions like work reporting requirements that hurt access to coverage and do absolutely nothing to help people find work, provider tax policy changes, limitations on state-directed payments, restrictions on states' ability to care for undocumented immigrants, retroactive coverage provisions, and changes to marketplace health insurance plans that will make it harder for people to get coverage. All of these could lead to coverage losses for more than 10 million people who depend on Medicaid for essential care. These harmful proposals threaten the health and stability of the very communities we're called to serve. We are also deeply concerned by the bill's failure to extend the Affordable Care Act's enhanced premium tax credits. Without action, 5 million Americans, including nearly 2 million living with chronic conditions, could lose their coverage, and millions more would face skyrocketing premiums and unaffordable care. Proposed changes to the Supplemental Nutrition Assistance Program would further jeopardize food security for families already struggling to make ends meet, compounding the health and economic burdens on low-income communities. Access to nutritious food is essential to keeping people healthy. Programs like Medicaid and SNAP work hand in hand to support the well-being of our most vulnerable neighbors, children, older adults, people with disabilities, and low-income families. As Congress debates the future of Medicaid, we urge lawmakers to remember that health is just not about treatment. It's about prevention, dignity, and ensuring that everyone has access to the care they need in order to thrive. We urge the Senate to protect and strengthen the programs that uphold the dignity, health, and well-being of all, especially those most in need. At CHA, we firmly believe that healthcare is a fundamental human right, essential to human dignity and flourishing. I would now like to introduce Wright Lassiter III, CEO, CommonSpirit Health. Wright?
Thank you, Sister Mary. I couldn't agree more with your opening comments and appreciate having the opportunity to share concerns from CommonSpirit Health along with my colleagues who are here today for this briefing. CommonSpirit Health is proud to be one of the nation's largest providers of healthcare and one of the nation's largest provider of healthcare services to Medicaid enrollees. It is firmly part of our expression of human kindness that we believe as a ministry every person deserves. We provide care to more than 22 million Americans each year and provide care to nearly 6.5 million Medicaid patient encounters each year. Let me spend a brief moment introducing CommonSpirit so that those who hear this briefing understand our impact. The CommonSpirit, we own and operate 157 hospitals, including 29 critical access hospitals and 1 rural emergency hospital, as well as nearly 2,500 clinics and medical offices across our 24-state footprint. We are committed to a healthier future for all and a mission that serves all people, especially those who are vulnerable. We believe deeply that everyone deserves access to high-quality care. We provide services to all who enter our doors, those served by Medicare, Medicaid, commercial insurance, and those who have no health insurance. Medicaid helps us turn that belief into action and serves as a critical lifeline for families, children's, seniors, and underserved communities who are facing barriers to the care that they need to access. We are deeply concerned, Sister Mary, as you indicated, that the Senate is moving to take even more out of Medicaid than the $880 billion that was included in the House version. All of the proposed cuts will have significant negative impact on CommonSpirit's ability to continue to serve patients in the communities that we serve. As we all know, hospitals are still recovering from the pandemic. CommonSpirit's like most in the industry, and we're striving to turn around the losses created by the COVID pandemic. The proposed cuts that are on the table today will impact that progress and will create a perfect storm of negative impacts. Fragile financial status, more aggressive commercial insurers denying reimbursement for care, and now massive Medicaid funding cuts. For us and our colleagues across the healthcare industry, it adds up to individuals not being able to get the care that they desperately need and putting the healthcare ecosystem at significant further risk. As we think about the cuts, we think about loss of access to care, as I mentioned, and at the center of these cuts is a profound impact that will be had on individuals. Broadly, we talk about loss of access to care, we talk about financial impacts to hospitals, and we talk about service reductions and potential closures. But our focus should be on the individual patients, those human beings who receive access to preventative and life-saving care that allows them to be productive individuals in our country. It's hard to go to work or care for your family with untreated hypertension, high blood pressure, diabetes. Worse yet, what happens when that individual has a stroke that could have been prevented? We already have maternal care deserts across many places in the country, and frankly, across many places where we serve, where women have to drive hours to deliver their children, which can have negative outcomes for the health of both the mother and the infant. The cuts that are proposed will make that situation even worse. At CommonSpirit, 56% of the babies that we deliver are covered by Medicaid. We're concerned that millions under this plan will lose coverage, that hospitals will face even greater funding gaps, leading to hard decisions around services, staffing, and most importantly, our most vulnerable among us will be pushed into deeper crisis. Quickly, a couple of examples that I would cite for you. As we think about our footprint and the communities we serve, I would highlight a couple examples. In Kentucky, Kentucky ranks 5th highest in the nation for poverty, 3rd highest with disabled individuals, and at the top in poor health. The use of the provider tax and state-directed payments has stabilized access and improved health outcomes in the communities that we serve in Kentucky. That program has been directly responsible for significant improvements in the health of our patients, as demonstrated by significantly reduced unplanned readmission rates, early detection of blood infections called sepsis, and more than a 25% reduction in serious infections. Each of our hospitals in Kentucky have specific metrics that they must meet to participate in the funding that we receive. Those outcomes save patient lives and save the Medicaid program money. For CommonSpirit alone, we think this could result in an $85 million annual reduction to our 7 Kentucky hospitals, 4 of which are rural. I would tell you that this is not sustainable for us and for those communities. For critical access hospitals, yesterday, the University of North Carolina Health Research Center released a report analyzing the current financial health of rural healthcare, as well as the potential impacts of HR 1 on rural hospitals. The report found that rural hospitals were impacted disproportionately by the proposed cuts. It's estimated that HR 1 would result in 1.8 million individuals in rural communities losing their coverage. Those are real people who deserve access to care in their own community. Our CommonSpirit Health critical access hospitals are on the list of at-risk hospitals with multiple years of negative margins and very high percentages of Medicaid patients. The fiscal impact to our critical access hospitals from the proposed bill will make it difficult to maintain access and could result in closures. In these communities, the hospital is usually the largest employer, offering well-paying jobs. When those hospitals close, the entire community is impacted economically. Let me just close by saying this. The examples are just two of many that I could cite, many that would play out across the CommonSpirit Health ministry. Cuts to Medicaid won't just harm those who really rely on it. Those consequences will ripple across the entire healthcare system, and hospitals and providers in our system and outside our system will be forced to make difficult decisions that will result in services not being available, not just for Medicaid patients, but for all patients. I'm hopeful that we'll stand together to protect Medicaid because fairness, compassion, and shared prosperity aren't just ideals. They're values that define us as a nation. Thank you, Sister Mary.
Thank you so much, Wright. And also thank you for the time. I understand that you're going to need to leave in about 15 minutes or so. So just appreciate you being with us today. So next, I'd like to turn this over to Laura Kaiser, President and CEO of SSM. Laura?
Thank you, Sister Mary, and thanks to all of you for being here today to hear from us. As Sister Mary mentioned, I'm Laura Kaiser, the President and CEO of SSM Health. I'm speaking today on behalf of all the people and communities we serve across Illinois, Missouri, Oklahoma, and Wisconsin, urban and rural communities. From St. Louis University Hospital in St. Louis to the city of Beaver, Wisconsin, also in our Oklahoma's Panhandle, our mission is clear. We are called to serve those most in need. That mission absolutely depends on Medicaid. The proposed $800+ billion cut to Medicaid will have devastating consequences, let me be clear. Cuts of this magnitude will leave more than 10 million Americans uninsured, and many of them live in the very communities where we serve. At SSM Health, more than 63% of the people we care for are covered by Medicare or Medicaid. Another 5% are uninsured. In Oklahoma alone, 1 in 5 residents relies on Medicaid or CHIP for children, and nearly half of them live in rural areas. These are not statistics. These are people, seniors, children's, working parents, people with names and stories. Let me share one of those stories with you. In 2020, Annie came to our long-acting injectables clinic for help managing a chronic behavioral health condition. She had Medicaid coverage, but no job, no transportation, and few resources. We provided her with some transportation services to and from her appointments, and over time, with consistent care and counseling, Annie began to find her footing. She got a library card as a first step, started reading again, and kept up her monthly treatments. Today, 4 years later, Annie is working full-time, has bridged from Medicaid coverage to commercial insurance, has a driver's license, a car, and a home of her own. That's what access to high-quality, compassionate healthcare looks like and makes possible. But we can't do it alone, as Wright said. It's putting our health system at risk and our nation's health system at risk to ensure that it is available for everyone. Our rural hospitals, like those at CommonSpirit, are facing enormous challenges: staffing shortages, rising costs, and in many cases, razor-thin margins or no margin. For many, Medicaid is the primary payer. When that support is weakened, the entire system teeters. When rural hospitals close, entire communities lose lifelines, not just for chronic care, but for emergencies, childbirth, trauma, everything in between. The idea of work requirements and eligibility verification may sound reasonable in theory. Today, in fact, almost 66% of those covered by Medicaid insurance already work full-time or part-time. The reality is far more complex. Without job training, transportation, support services, work requirements, and eligibility verification risk becoming barriers to care, not bridges to independence. Even proposals like a $35 copay sounds reasonable for non-emergency ER visits, seemingly small, but can be real obstacles for patients and low-income families who may depend on Medicaid for their insurance coverage. We are fearful that this will deter people who need care from seeking it, and in turn leading to more serious and more costly care when their care progresses into something that is more urgent and more acute. Our states also need the flexibility to fund Medicaid in ways that reflect their unique needs. For example, Missouri has one of the highest provider taxes in the country. In Wisconsin, who is self-funded, capping the rate at 2.3% limits our ability to sustainably support care. Let me leave you with one final thought. In our rural community hospitals, we are often the only option for patients to receive care. We have taken care of John for many years, a local resident with healthcare coverage through the government. We've also treated Sophie, someone who was traveling through the area, seriously injured in a car accident. She wasn't from the area, but she needed help, and we were there. This puts all of that at risk. That's what rural healthcare does. It takes care of the people that live there, and for all of us that may be passing through, a safety net. Bottom line, this is more than being about budgets and policy. It's about people, dignity, and the health of our communities. We urge you, Congress, to reject these cuts. Please work with us, providers like SSM Health, to strengthen our nation's health system, not further weaken it. Thank you.
Thank you so much, Laura. Now I'll turn this over to Chantel Krebs, President and CEO of Avera St. Mary's. Chantel?
Thank you, Sister Mary, for having all of us today. And Avera, I want to speak on behalf of Avera Health, and then I want to share a little bit more about Avera St. Mary's, our particular regional hospital in South Dakota. Avera Health, we are truly a leading rural healthcare ministry that's rooted in the gospel. And Avera is especially concerned about these cuts because truly rural health has been a part of our core of our mission for many years. I'll give you a little background. Avera has about 270 hospitals, clinics, nursing homes, and we cover about 72,000 square miles. And that is in our footprint with over 22,000 employees. So when we talk about rural healthcare is truly in our DNA. And I want to share a lot about the reductions. These funding reductions, it's a concern because it may force many facilities to reduce, and as Laura has shared, they reduce or cut these services across there. It could impact communities by closing emergency rooms, maternity care, behavioral health services, or even having access at all, as several have mentioned before. We are truly rural, and I want to share a little bit more about our rural hospital in Pierce, South Dakota. Gives you a really good idea of what we serve and of patients that would be impacted. Avera St. Mary's in Pierce, South Dakota, we have and are surrounded by about 4 of the 9 American Indian reservations around us. So there's 9 American Indian reservations in South Dakota. There's 4 in our central area. And our regional hospital, and again, located in central South Dakota, we serve roughly 13,000 square miles. That's not patients, I said square miles. That's truly rural. And I see Brad commenting, that's true. 21, almost 22% of the patients at Avera St. Mary's are American Indian, and they do not have access to hospital care. Maybe they have a small clinic or a small IHS hospital, but many of them, and I think none of them actually have obstetrics care. So when you think about that, they're driving over an hour or 2 to get obstetrics care. And many in South Dakota are driving an hour or 2 just to even have access to care. I'll give you an example of a recent hospital just south of us. Again, finances got tough. Finances are fragile. This hospital 2 hours south of us recently announced that they were stopping the offering the birthing services. Now those patients are driving 2 hours north to see us. Now think about that. Imagine driving 2 hours for a prenatal visit or to a hospital when labor starts. And that's truly a reality for many in South Dakota, is this far distance. And then you add winter weather on top of that. So we are truly a pivotal moment in rural healthcare. And and I think Wright had mentioned it, in the United States, I think more than 50% of the counties have no hospital-based obstetrical services, and South Dakota is no different. American Indian women, for example, are 2 to 3 more times likely to die from a pregnancy-related causes than white women. And in South Dakota, over 50% of the Medicaid population, they live in rural communities. And when we define rural communities in South Dakota, we define them of towns of 500, towns of 1,000, towns of 1,500. That is rural healthcare. And those are the patients that we serve. And I think the vast majority of people in South Dakota, they actually work and have a work requirement and do work that receive Medicaid. So they're already working. I also expand a little bit on our long-term care facilities. In just my smaller region in central South Dakota, we have 2 long-term care facilities, and I think Brad might touch on long-term care, but we have one that has residents of about 57 and the other one has about 33. These cuts to Medicaid would force states to make difficult decisions about funding for long-term care facilities. And we know that this funding doesn't even cover the cost of providing care. And I think the residents, as far as the number and percentage, I think 50% of our residents in our long-term care facilities are receiving Medicaid funding and recipients. So I'll just close with what I've shared with you and reiterate what Wright and Laura has already said, that Avera, we oppose any of these harmful funding reductions because they'll impact our rural populations. And I just shared with you, it'll impact moms, newborns, American Indians, and individuals that live in small towns of 500, 1,000, 1,500 people. And they are driving over 2 hours to get care already. These are the folks that will be impacted the most.
Chantel, thank you so much for sharing your perspective and your experience. Next, we have Gabriella Sines, Senior Vice President at CHRISTUS Health. Gabriella?
Thank you, Sister Mary. I am first honored and humbled to be here representing not only my CEO, Ernie Seydoux, on behalf of CHRISTUS Health, but also our sponsoring congregations, because we truly are the ministries that are following through on that legacy of their mission and their original calling. That is an honor, it's a responsibility, and it's something that we're all very proud of. But when we talk about that original calling and really the purpose for a lot of healthcare in our ministry, it really is about access to care. At CHRISTUS, we are really proud to be serving Texas, Louisiana, and New Mexico. We are one of the largest, most diverse geographically in our region. But really, when we talk about the locations, we are mostly rural. And the reason many of us talk about rural healthcare is because it is about access. That was our original calling. That is why we go to the places that need us the most, because we are there to help those that otherwise would not be able to advocate for themselves or those that need the care. We talk about HR 1, and in both versions, I don't want to continue to sound the alarm, but we are sounding the alarm because this really would be devastating to our people that we serve. When you look at our demographics, we are representing and serving people that are over 60% of them are on government-sponsored care. So we're talking about Medicaid, uninsured, and those that are otherwise not able to even access healthcare outside of going to the ER. And as we all know, at that time, it is many times too late, not only from a healthcare perspective, but also from a cost driver perspective. Last year, CHRISTUS did serve 1 million encounters of Medicaid, and an additional 500,000 of those were uncompensated care. You know, we are really proud of the areas that we serve. We are looking at the populations that would be losing coverage under HR 1. We are estimating about 150,000 that will be losing Medicaid coverage in areas and towns like Texarkana, Texas, and Tyler, Texas. When you look at those two populations alone, 150,000 is the makeup of those two together. That is devastating to the care and the communities that otherwise would not have that care. We also talk about the policy. We always also say that what happens in Washington, D.C. or in any of our state legislatures really does matter. We know policy cuts and budgets are something that you have to work together on to try to understand the costs and implications. But when we talk about the provider and the directed state payments, we're looking at $4.3 billion of payments that are going to be pulled from the healthcare financing. That number is large, and that devastation will be just as large. That is the infrastructure of who we are as healthcare, but also as a Catholic healthcare ministry. And those are real people that we are serving, and then will be real consequences. Another aspect that I think all of us are really grappling with is the innovative Medicaid and innovative programs that we all do and we all serve that are not sponsored or reimbursed by the government or by any of our payers. Those are going to be areas that we're going to have to really consider and look at. Just like the ones where we have nurse practitioners going into our rural communities and focusing on Medicaid enrollees to help drive readmissions down. Those are the type of programs we are really proud and tout on a regular basis. They are real issues and real programs that help the overall access to care. Under this bill, a lot of those potentially could not happen. In the end, we also have concerns with really looking at the driver of costs of the bill. We still have the costs that we're still going to have to grapple with, whether that's the drugs, the equipment, the supplies. So we are going to ask and encourage our senators and our House to really reconsider H.R. 1 and really focus on the devastating impact to this infrastructure and to the millions of people that we serve. So thank you.
Thank you so much, Gabriella. And lastly, we'll hear from Brad Coffey, Senior Vice President and President of Covenant Health Foundation. Brad?
Yeah, thank you, Sister Mary. Can you hear me okay? Are you able to hear me okay?
Yes, fine,
Okay.
Brad.
Sorry about that. Thank you. So thank you, Sister Mary, and thank you to the folks who've spoken before me. I am indeed Senior Vice President with Covenant Health, and I'm here representing my CEO today, Steve Grubbs. Covenant Health is a health system that was founded by the Grey Nuns of Montreal. We were formed in the 1980s, but our facilities have been operating by the religious orders that founded us for over 100 years. Today, we're comprised of hospitals in Maine, New Hampshire, and post-acute facilities in Maine, Massachusetts, Rhode Island, and Pennsylvania. I'm going to focus my comments on how the Medicaid cuts would impact those served by our hospitals. Maine's the oldest state in the country. New Hampshire is the second oldest state in the country. And for many years, but even more so since COVID, Maine and New Hampshire have really been struggling with shortages of providers and nurses. We have a true problem with our demographics. We just don't have enough young people to care for the aging seniors, as well as the rest of us. And the current reimbursement rate from Medicaid is not nearly enough to cover our costs, pay our staff, and invest in the health of our communities. The proposed cuts would be devastating to our hospitals and the 204,721 people we serve. According to reputable sources, the proposed cuts would reduce the number of people receiving Medicaid in New Hampshire and Maine by 14% in each state. In our three hospitals, we care for 34,922 people who are on Medicaid, and the cuts will reduce that number by 4,889. I realize those numbers are small compared to some of the numbers that have been thrown around, but just remember, every one of those is a person, a mother, a daughter, someone who's important to someone else. These are really significant cuts to these people. This means that we will have to choose, that those persons will have to choose to put off necessary care, tests, and treatment as long as they can. And without access to regular routine care, they will likely end up in our emergency departments more compromised and sicker. Of course, we will treat them, but we will not be reimbursed for that care. Like other parts of the country, we in Maine have been seeing hospitals close, programs cut. People in our communities, my neighbors, friends, and family members are anxious, worried, and concerned about access to health care. Every single day, I receive calls from people saying, I cannot get access to this type of doctor. I cannot get in to see this type of provider. People are really worried at a local level about how the current situation is already impacting them. They struggle. They make the calls. They talk to their neighbors, their friends. They ask, how do we get access? They often have to travel far away, drive to Boston, drive to New York. I mean, they're not just going 45 minutes or an hour away. Sometimes they're traveling well beyond that to get access to certain specialists that we just can't afford to have in a rural state like Maine. The proposed cuts to Medicaid will reduce funding to our 3 hospitals by $12.7 million. That would be devastating. Our hospitals typically operate at a loss or barely break even. This means less money to pay living wages for our staff, less money to replace equipment, less money to ensure we have adequate staffing, a reduction in the quality of care for an aging population, a reduction in access. And as a Catholic faith-based organization, we have a number of programs and services that we offer to people in our communities that do not have any kind of reimbursement model. For example, in Bangor, Maine, we provide care to victims of domestic violence and abuse and assault and rape. It's a program that is operated by a team of 24/7 RNs who care for people coming in on a daily basis to our emergency department. And there's very little money to reimburse them for that care. We do it because we're committed to it, but it makes it really hard to provide services like that to our communities if we're going to be looking at losses like this. We just won't be able to continue doing those things. According to the teachings of Jesus in the book of Luke, and I think we all know this, blessed are the poor, for yours is the kingdom of God. Those on Medicaid are the poor, and we have a moral duty to care for them. We should not be talking about cuts to Medicaid. We should instead be talking about adding funding to Medicaid and reforming how we provide healthcare in this country. This is the wrong discussion for us to be having to have. Make no mistake, these cuts will impact all people, however, not just the poor. Access to healthcare is already a challenge, regardless of one's financial condition. The financial impact to hospitals such as ours will be devastating. The health impact to our communities will be devastating, including to the hundreds of businesses in our rural parts of Maine who already have upward financial stress on their commercial insurance plans. That will just get worse for them. Cuts to Medicaid are morally wrong, and they will impact everyone. Thank you, Sister Mary.
Amen to that, Brad. Thank you. And I'd like to thank Wright, Laura, Chantel, and Gabriella, each of you, for sharing your experience on how these proposed cuts will have devastating impact on the people we serve. So I think we're now going to open it for questions. Marie?
Yes, thanks, Sister Mary. Our first question is from Bloomberg. The House proposed to freeze provider taxes. Senators are proposing to go further, both freezing provider taxes and for Medicaid expansion states, phasing down the safe harbor limit from 6% to 3.5%. What does this mean for rural hospitals?
I can jump in here. Thanks, Marie and Bloomberg. I'd like to say, first of all, it's just the further the cuts that are made, it's the more devastating it is. I mean, that's the bottom line. Is every state has some type of provider tax, but any adjustments you're pushing back to the states, and then the state's burden becomes greater. But how are they going to manage funding? But again, it's just the push of further and deepening cuts. It's going to hit even harder for these rural facilities. And I'm speaking on behalf of rural communities, towns of 500, 1,000, 1,500. So it's just extreme recognition of such an extreme cut and how it truly is going to impact rural South Dakotans and rural Americans.
May I add to that, Chantel?
Please, Laura.
So I would also just offer that the cuts in provider taxes are levied on providers to pay in to help states fund part of Medicaid that each state pays for, and it's done differently. The formulas vary from one state to another. The bottom line is that Medicaid payments currently are less than the cost of care. And you heard from Brad around ensuring that we're paying living wages, competitive wages, et cetera. This is not a giant profit-making machine. This is about ensuring the total cost of care is covered. And so Medicaid is already supplemented by other means within health systems that have very thin margins to begin with. So an impact on provider taxes lessens the total number of dollars that are available to pay for needed care for Medicaid recipients. So it's just a reduction in total revenue that can go to offset the cost of care and the expenses that are associated.
Again, to ask the question, you can please type it into the Q&A chat. The next question comes from Becker's Hospital Review. Senate Republicans propose Medicaid cuts go even deeper and broader than those outlined in the House bill, which caught many by surprise yesterday. I know all of you are deeply engaged in advocacy efforts at both state and federal levels. As we approach the GOP's stated goal of moving this bill to the president's desk by the July 4th deadline, he would like to hear, what are you learning from conversations happening behind closed doors on Capitol Hill, and what signals or insights are you picking up that you hope about potentially averting these steep cuts?
Yeah, I'm happy to jump in on that. I've been talking with our congressional delegation. What I've been hearing is that there's a really strong desire to not see our hospitals that are already stressed further stressed. They're committed to standing up and making sure that the pretty weak financial situation doesn't become weaker. At the same time, I'm hearing there's some willingness to consider a work requirement on the part of some. And the question is, how might that be implemented in a way that has less damage? So some of the advocacy in this area is to push back that starting date for when the work requirement might go into effect. We've heard how work requirements are politically popular among some, but the reality is to implement a work requirement program in roughly 18 months, which is what the House bill calls for, just is not even close to being realistic. And the amount of funding that was put into the HR 1 proposal was about $100 million for all of our states to implement work requirements. So I guess to answer that question more succinctly, we are hearing that there is some potential appetite for work requirements. There's also some willingness to consider how might we mitigate some of the harm from the work requirements in terms of the financial impact and the impact on people.
The next question comes from CNN. How much of a concern are work requirements and the loss of coverage compared to provider taxes? Also, how common is it for Medicaid state-directed payment rates to be higher than Medicare rates?
Marie, could you repeat the question? You cut out.
Yes, sorry. How much of a concern are work requirements and the loss of coverage compared to provider taxes? And how common is it for Medicaid state-directed payment rates to be higher than Medicare rates?
Well, I'll just reiterate again the work requirements that the vast majority, and I'll speak for ourselves in South Dakota, that who do receive Medicaid are working. And so when you look at the work requirements in some of these states, and I think a majority of the states, those that are receiving Medicaid, especially on those that were in the Medicaid expansion, are working. So I'll focus on just that answer there.
I don't know the answer to the second part of the question, but I do know financially the work requirements have a much greater impact than the provider tax reduction, theoretically, according to everything that I've read. So that's just from a financial perspective, a greater worry. Of course, I haven't seen the analysis on how much the drop, that they're talking about in the Senate, what that would do. That it might make it even closer to what the impact would be financially being caused by the work requirements. I read about the Senate version this morning, and there's some language in there that would limit the exemption for people, I think, if they're caring for teenage children. I saw that and I thought, boy, that could be really hard on some people who are at home trying to care for kids coming home from school to go off and find work. I don't know how realistic that is for most people. So I wonder about the wisdom of that. I'm not sure why that's being pursued. That doesn't sound like a good idea to me.
I would just add that it's hard for us to say that one is worse than the other. I think the impact is devastating to both people involved, whether it's the enrollee that is going to be losing Medicaid coverage because of new requirements. For the cuts, we're really talking about the infrastructure. And that is for the state-directed payments, whether it's shifting it to the budgets, to state budgets to make those decisions, or even the local provider fees. A lot of times, the reason it can be complicated is because there are so many different local counties and government entities involved on creating and tailoring what is best for that community. And that involves all of the stakeholders within each local community coming together, working with their community hospitals and focusing on access to care and providing care to those people. So they're both going to be devastating, but just to different aspects of our healthcare delivery system.
And just to add a little bit additional, our analysis, and there's a lot of different analytics that are going on in many, many different places. For us, the overall impact, if you roll it all together across the nation, is that the impact of the work requirements will be an estimated savings of about $344 billion. And it's estimated that that's going to impact almost 5 million people. The provider taxes is estimated to have an impact of about $89 billion, and it will affect about 400,000 individuals so that they will no longer be covered by Medicaid. It is a roll up, to Gabriella's point and to Chantel's points, but those are the evaluations that we have at this point in time. And it does go to the very bottom line, which is the cost of providing care to people that need the care is not going to be covered. And what you're hearing from all of us is that we've been pretty good at kind of sucking it up to date. We can't do it anymore. There's no additional hidden funds somewhere or monies that we're all going to suddenly find. We are doing our best based on the mission and the dignity of each person that we serve, but it's simply not an equation that works.
Our next question comes from Kaiser Health News. Have your hospitals reached out to GOP governors who have been silent on Medicaid, and how vital is it to get them on board to protect Medicaid?
I'll weigh in again, and others will too. It's vitally important. Look, we're all in this together. We are the United States, and we have 50 states, so 50 governors, Republican and Democratic alike. And this is about our citizenry and taking care of people that need care. And so it's really important on such an important issue that all of us are informed and leaning in to find a solution that will work.
And I'll just add as well, I agree. It takes all of us. It is very important for us to reach out to each of our governors in the states we represent. I think there is a misnomer out there that if you are in a non-expansion state that you're going to be taken care of, and that's not the case. And so from a state like Texas, where we reside heavily and serve very proudly, this still would be devastating to our ministry at CHRISTUS Health.
Our next question is from Inside Health Policy. Could you discuss the impact on dual eligibles?
I feel like I keep weighing in, y'all. So I'll go first again, but then now someone else will go first next. I think it's I'm going to sound a little bit like a broken record. So dual eligibles are people that have very complicated medical conditions, and so they may be eligible for Medicare and Medicaid. And so the impacts are that the cost of needed care will not be covered, and so it will put dual eligibles who have fragile medical conditions at an even more vulnerable state.
And just to add, Laura, I think, again, putting pressure back on the states. I mean, that's the bottom line. It's what happens is that each of the states' budgets are tight already, and this would only put more pressure back on the states.
And our final question is from the Morning Sentinel in Central Maine. So I think, Brad, you can start with this one. What plans are in place at Covenant Health to prepare for the financial health and health fallout from this bill? And how would this bill impact small hospitals like St. Mary's and St. Joseph's in Maine? And what services would be at risk of being cut?
Again, Marie, I feel it's counting out. Maybe it's just my computer, but could you repeat that again?
Sure. I think this is for Brad. It's from the Morning Sentinel in Central Maine. What plans are in place at Covenant Health to prepare for the financial and health fallout from this bill? And what would the impact be on small hospitals like St. Mary's and St. Joseph's in Maine?
Yeah, so we obviously hope that these proposals don't get passed, and we are advocating hard to lobby our own senior senator in Maine to oppose these cuts. And we have shared quite a bit of information about how the proposed cuts would impact our hospitals here in Maine. So that's our hope. But you're right. I mean, the question's a fair one. We need to be asking ourselves, what are we going to do? And, we will, over the course of the ensuing months, be looking at all of our services and asking ourselves, what are those services that, if they were reduced, would have the least impact on the people we serve. I mean, we are so committed to serving people in our communities. The last thing we want to see is any further reductions. Every time we hear about these reductions in our states, it pains us. You know, that's what we would probably have to do as a result of these cuts is remove some of the services that we provide.
And to add on to what Brad just said, I mean, we have to look at, and not just Avera St. Mary's or Avera Health. I think there's many facilities and hospitals across South Dakota that's going to have to look to see, do we need to reduce or cut services? That's going to impact care and access to care for everyone. You know, a community may lose emergency rooms. It may lose maternity care. I shared that story where that just happened 2 hours south. So it's real, and it will impact rural health care, behavioral health, and in some case, like I said, access to any care. American Indians and our reservations in South Dakota don't have access to care, and it will impact those that are providing that care, even though we may be 2 or 3 hours from those individuals. So rural health, it will be impacted.
Thank you, Sister Mary. There are no further questions.
Thank you, Marie. And once again, thanks to all of you, and particularly thanks to the representatives from the media who are with us today. We need your voice. We need your coverage in really communicating this important message. You know, Medicaid cuts, as you heard, will have real implications and dire impact on our hospitals, our patients, our communities, and those we serve. And we'll continue to work with federal lawmakers to ensure our health safety net remains intact so that our health systems can continue to provide the vital care that is needed in those communities. Thank you very much.
Thanks, Sister Mary.
Thank you.
Thank you all.